So if you have any problem seeing the images, let me know. If for some reason, you can't see them at all, I can try and do a few things so you get a better view, but it really depends on, the quality of images. So hopefully they're broadcasted well. I didn't have any issues when I gave this presentation on Tuesday to the interns, who, by the way, did very, very well. So we'll see if the second and third years can beat the first years in terms of ultrasound. All right, so let's get started. So we got a 79-year-old man, medical history of coronary artery disease, hypertension, diabetes, coming in with cough, shortness of breath, dyspnea on exertion, and chest pressure. A little hypotensive, slightly tachycardic, tachypnic, hypoxemic on non-rebreather, afebrile with a temp of 98.6. In the ED, like many of the patients that you'll receive, he was given vancomycin, cefepime, azithromycin, solumedrol, nebs, aspirin, a liter of fluids, and probably a pending order for Lasix. So now your decision is, well, what's going on with this patient? Now you're coming down to evaluate the patient. So let's see if we can figure out utilizing ultrasound to help us make a differential diagnosis. And remember, that's what ultrasound does. It allows you to make a differential diagnosis. It doesn't point you to the diagnosis, right? This is where your clinical knowledge, your skills, your ability to interpret labs and integrate all of the information really comes into play. So we have this, and this is a representative finding in the anterior lung fields bilaterally. So what do we have here?
B lines.
Good, B lines, absolutely. And just so we familiarize ourselves with B lines again. So B lines, sonographic definition, vertical lines extending from the pleura off your screen. They move with the pleura if the pleura is moving, and they're dominant. So they efface or obliterate A lines. So that's your sonographic definition of B lines. So what do B lines represent?
A consolidation, like fluids inside the alveolar, or like pneumonia, but given that you mentioned it's bilateral, so I would go with pulmonary edema.
Okay, so I like how you're coming up with a differential. That's fantastic. So the way I always think of it, and it keeps my mind broad, I don't jump to any pulmonary edema or pneumonia. I say it's an interstitial or an intraalveolar filling process, something going on. It can be fluid, which can be transudative or exudative, right? It can be other things such as interstitial lung diseases, lymphangitic spread of cancer, alveolar hemorrhage, pulmonary edema you mentioned, pneumonia, ARDS. We saw this in COVID as well. So the differential is broad, but when I think about it, I say interstitial or intraalveolar filling process. Now, if that's bilateral, puts us to different ideas on what this could be. If it's unilateral, maybe points us in a different direction. So now we looked at the lungs, we saw some B lines anteriorly. So now we look at the heart. And what view is this?
Parasternal long axis.
Parasternal long axis, correct, Yasmin. And what is this right here? We'll just go through the anatomy real quick.
LA.
Good, and this is?
LV.
Good, and what valve is this?
Mitral.
Good. This is what?
Aortic valve.
Good, aortic valve up here. LVOT, our left ventricular outflow tract here. What is this?
The aorta.
Good, the ascending aorta, descending aorta. And what's this?
RV.
Good, the right ventricular outflow tract. So that's what it's catching right there. Good, so what do we think of this parasternal long axis view?
Dilated LA. I'm not sure if that is like mitral stenosis. It doesn't like open as normal. I'm not sure. I think so.
Okay.
Looks like hypokinesis, like global hypokinesis. That's why the anterior leaflet of the mitral valve is not getting closer to the septum the way it should, right?
Excellent, excellent. So we have, whenever you have one view that's hypothesis generating, you probably heard me say this when we've done ultrasound together, those of you who've worked with me. So you have one view, it's hypothesis generating. You want more than one view to confirm what you're seeing and come up with a differential and then ultimately a diagnosis. I agree with you. I agree with both of you. So definitely there is some hypokinesis to the left ventricle, right? So depressed left ventricle. In this view, we can look at the anterior leaflet of the mitral valve and see how close it comes to the septum. We like to say 1 centimeter, some books say 8 millimeters. That's the E-point septal separation. So in early diastole, when you have the anterior leaflet opening up, how close does it come to the septum? If it doesn't come within 1 centimeter, then we're saying that there's possibility of reduced left ventricular ejection fraction, right? When you were saying, Nora, mitral stenosis, it's very tough to say. You'd really want to throw color over there, right? And see if there's turbulent flow distal to the valves entering into the left ventricle. You'd also want to look at something we call pulse wave Doppler, right? So you'd look at the flow across it, and then you'd actually measure and calculate a gradient. And then by a continuity equation, you can actually calculate the surface area. And then you would be able to determine if somebody has mitral stenosis. So much more complex beyond the scope of this lecture, but I like the way that you're thinking, because if you have mitral stenosis, that will affect the valves independent of left ventricular function, right? So again, these views, there's limitations with interpretation here. So if I have a valve which is completely blown and it's slapping the septum here, it tells you nothing about ejection fraction. It just, the septum, the leaflet's all over the place. What's this right here?
It's a coronary sinus?
Yes, it's excellent, Fatima. It's the coronary sinus. Good. It's a little bit dilated here, right? The coronary sinus empties into the right side of the heart, into the right atrium. So tells you that maybe there's some increase in right-sided pressures. Certainly you can see much larger dilated coronary sinuses, but usually it's not something that's a prominent view on your parasternal short axis. Good. So what view is this?
Parasternal short axis. At the level of
Niru, it's good to see you. I'm glad you joined in. Yes, this is the parasternal short axis at the level of the what?
The papillary muscles.
Good. Papillary muscles here, there. They're like boxing gloves is sometimes what we talk about it, right? Just to familiarize ourselves. And we're having a good view of the myocardial wall and the endomyocardial border as well. So we can tell a lot about the ejection fraction here. So what do we think of the heart function in this view?
This decreased LV contractility or LV function.
Yeah, I agree with you. It's depressed. So we had one view in the parasternal long, which is giving us evidence that we might have depressed or a hypocontractile left ventricle. Now we have additional views which are confirming this. And definitely at the level of papillary muscles is a great view to look at your overall global function. With that said, you do want to scan along the apex, the papillary, the mitral valves, because this is a three-dimensional structure. So you really want to scan to make sure that there's no regional wall motion abnormalities. And here we're looking at a few things to look at LV function. The eyeball technique, which we tend to teach in point-of-care ultrasound, looking at myocardial thickness. So between diastole and systole, do I have an increase in 1/3 thickness of the myocardial wall? And clearly we do not have that here. And then if I have a good view of the endomyocardial border, which is this interior part of the heart, do I have good endomyocardial excursion? So all the walls coming in and obliterating the LV cavity by at least 1/3. And we do not have that here, right? So already we're getting an assessment of a depressed left ventricular ejection fraction. Again, for the point of POCUS, for us in critical care, we really want to know if somebody is hyperdynamic, if they're normal, if they're depressed, or they're severely depressed. Whether or not their EF is 30 or 35% really does not have a big clinical implication for us, right? We really, for long-term, for cardiologists, they want to know which direction the EF is going. That's important. But for us right here in the acute setting, it's, are they hyperdynamic, are they normal, or are they depressed? And that's what we're trying to really gauge here. So now we turn this view, and what view is this? I see Nero turning her head and tilting a little bit.
It's a two-chamber view.
Excellent. So it's an apical two-chamber. You might also hear it as an apical long axis view. This is the left atrium. This is the left ventricle. This is the mitral valve. This is another great view to look at LV function, but it also can give you a good assessment if I was to throw color and also continuous wave Doppler over this area. It can tell you if somebody has, like you were saying, Nor, mitral stenosis or mitral regurgitation. right? So a lot of different things that you can get with this view. Additionally, by this view, you can look at different walls. So here I'm looking, I'm looking at the interior wall, apical cap, and this is the inferior wall. A little bit different views in terms of the walls that you can see. We'll talk a little bit more about this in additional cases, but this is the benefit of knowing how to get these alternative views. And Nero, what do we think of the LV function here?
It's definitely depressed. It's not good endomyocardial excursion or myocardial wall thickening. And it seems to be kind of global, including the apex.
Excellent. So what's our diagnosis here? So, you know, if you have a pen and you want to write things down for what our findings are so you can remember them, I think that's great. But, you know, we'll go through each image. So we saw in the lungs, what did we see?
V-line pattern.
Good. In the heart, what did we see?
Hypokinesis or low function.
Good. Low function. I like it. To the point. And so what do we think our diagnosis is if we put this together?
This is cardiogenic shock, or I don't know, pulmonary edema, probably. That's what's going on.
Good. Excellent. So B-line profile, severely depressed left ventricular ejection fraction, systolic heart failure, and pulmonary edema. And if you got a chest x-ray on a patient, you might see something like this. This is a very classic finding that we tend to describe. This is usually on the pulmonary boards. It's the bat wing pattern and pulmonary edema. This is something we typically see. It's not obviously the only way that pulmonary edema presents, but this is just a classic presentation. Good. So you guys, you dunked that one. It was a perfect evaluation. So let's start stepping up the intensity here. So now you have a 42-year-old man with hypertension, diabetes, coming in with chest pain and shortness of breath. Seems like the same complaint. So obviously it's going to be the same condition, right? Hypotensive, tachycardic, tachypnic, hypoxemic, afebrile at 99.1. I don't believe in low-grade fevers, so you're either febrile or you're not febrile. So what do we have here? And I kind of gave you a hint already with the view.
External lung axis.
Good. And so what do we think? Now that we went over all the anatomy already, so I don't think we need to go over it again. So what do we think of the heart function here?
Hyperdynamic.
Good. And why do you say hyperdynamic?
It's all shut down. And there is like obstruction of the outlets, I believe.
So you bring up some good things. I agree with you. It does look hyperdynamic in this view, right? The anterior leaflet is hitting the septum here. So that's one indicator. What you're talking about is, Nora, a very important concept, again, beyond the scope of this, more advanced, but you're talking about a dynamic left ventricular outflow obstruction, which can occur in people who have hyperdynamic heart disease, whether it's due to, say, sepsis, or if they have HOCM. HOCM tends to be a more fixed, but sepsis, you can have a hyperdynamic and dynamic outflow obstruction. Basically, the anterior leaflet blocks the LVOT and it's being sucked in. And so you'll have something called systolic anterior motion of the mitral valve, also known as SAM. Again, that is a diagnosis. You can't just look at 2D and get that. You'll have to put M mode over there. You'd actually have to use pulse wave Doppler to go over your LVOT and see that dynamic obstruction. But I like the way you're thinking, because definitely there's a hyperdynamic LV here. We can see that the anterior leaflet hitting the septum. What view do we have here?
Short axis.
I guess there's only four residents who tuned in: Nora, Yasmin, Nero, and Fatma. I just see 4 people answering everything, which is okay. So parasternal short axis at the level of the
Papillary muscles.
excellent papillary muscles. And what do we think of the LV here?
I mean, the LV function seems to be preserved.
Good.
I don't know if I'm able to comment on it being hyperdynamic. It doesn't seem like the cavity is nearly obliterated.
Okay. Okay. So definitely, at the very least, it's a normal ejection fraction, right? So 50 to 70%. We have good myocardial thickness. We have good endomyocardial excursion. So let's take it to the lungs now. What do we have here?
I think those are A lines.
Pardon me? I couldn't hear you.
Are they A lines?
Yes, absolutely. So A lines. So what are A lines?
The reflection of the pleura.
Excellent. So it's reflection of the pleura. So it's reverberation artifact. That's all it is, artifact. The ultrasound is up here. The beams are hitting the pleura. They're bouncing back and forth, being reflected in air. So that's always good, right? You see this, you say, hey, the guy's good. I'm waiting for an answer.
Mostly, yes.
Okay, so air and lung is good, right? I think we all would agree on that. Most of us, hopefully. Can air and lung be bad?
Yeah, at least we can rule out like interstitial and intraalveolar processes like pneumonia or pulmonary edema or hemorrhage as a cause for his symptoms.
Okay, at that point, right? Always remember, whenever you're doing ultrasound, especially in the lungs, you can rule something out at that particular point. It's just an ultrasound beam in one area. So I agree with you here. I don't see any B lines. I see A lines. What is another condition where I can have air in the lung and somebody could be very, very unstable?
Pneumothorax, but we have the sliding sign, so I don't think we have it. We have no pneumothorax.
So this is what we call an A profile here, right? A lines and sliding lung is an A profile. So now let's take a look at the left side. What do we think?
Also like A lines, but I don't see like also lung sliding in this view. So
good. So what are you concerned about?
Thorax.
All right, excellent. So what would you want to do next to get a better view of the pleura?
Put it on M mode.
Okay, so let's zoom in and then maybe do M mode. So now we're zooming in a little bit.
Lung point.
Lung point. Excellent. Can everyone see the lung point? So this is diagnostic of a pneumothorax right there. And basically, you have normal sliding lung between the visceral and parietal pleura right here. And then air is separating the two. So this is why you get that lung point, and you can actually see it right here. So this patient is unstable. They're hypoxemic. What are you going to do?
Chest tube.
You're going to, Christina,
Needle decompression. Maybe, I don't know.
I'm sorry?
Maybe do a needle decompression if it's very unstable. But
Okay, good. So we saw, hyperdynamic left ventricle, A line profile on the right, left A prime profile. So just so we're familiar again, you have A lines, you have sliding lung, that's an A profile. A lines and no sliding lung, that's an A prime profile. So this is the terminology you want to be thinking about. And a left lung point. So tension pneumothorax. So definitely, this is what you want to do. This is easy, much easier than putting in a chest tube. Chest tubes take time, at least, for me, like 8-10 minutes, if you're going to do it sterilely. We had to throw in an emergent surgical chest tube in the ICU the other day, but you can do it emergently, but that's not ideal. But you can get a needle and you can do a decompression, right? And what you want to do is go in the midclavicular line. You want to go in the second intercostal space above the third rib. And then you get a 16 gauge, clean the area, and you obviously put the needle in and decompress. Life-saving intervention, but it's not a permanent fix, right? So yes, you will need a chest tube, and that's something that you'll have to get prepared and get ready, because the lung obviously will reaccumulate with the pneumothorax again. So what are you going to do? This is great. You have a nice thin guy here. He's got no musculature. That you got ribs everywhere. You're not always going to see this. Sometimes you're going to have somebody like this come in. What if Arnold comes in and he's got a pneumothorax? You're not getting a 16 gauge through here. He's been working too hard. He's not going to let you go there. So what are you going to do? You don't let Arnold die.
We can do other like the mid-axillary line.
Beautiful. So you can go into different areas. So you can go into the mid-axillary line, either the anterior or the posterior mid-axillary line, where you can get his vulnerable spot and you can stab him right there and save his life. And there's actually ED literature looking at this, going in the mid-clavicular versus the axillary. And they're equal in efficacy in terms of a needle decompression. You know, typically pneumothoraxes tend to go at the apex of the lung because air rises, right? That just makes sense. But usually, you know, if you're having a tension pneumothorax, it's not a little 1 centimeter pneumothorax that's causing significant instability, right? You are having a profound accumulation of air, which is then causing a mediastinal shift and an obstructive shock, right? So usually when you have a tension pneumothorax anywhere in the second intercostal space up into the mid-axillary line will be beneficial. And the ED literature has actually looked at this. So remember, if somebody's coming in, and more likely at our hospital setting, you're not going to get somebody who's just got gigantic pecs, but just morbidly obese, right? So that's what we typically see here. You got to find other areas where you can stick the needle, and really you can find it in the mid-axillary if you need to. All right, nice job. So let's go to the next case. So 32-year-old male, no known medical history, coming in with fever and chills for the past few weeks, no cough, no urinary symptoms, borderline hypotensive 105/67, little tachycardic of 103, slightly tachypnic at 24, slightly hypoxemic at 94% at 3 liters, and febrile to 101.5. So we're going into the anterior lung fields. We're trying to figure out what's going on. And what do we see here?
A lines in the lung.
A lines, good. And sliding lung, right?
Yeah.
So what profile?
A profile.
A profile, excellent. And now we're going into this is a representative image, so bilaterally. Now let's look into the axillary lung fields. What do we see?
The curtain sign.
The curtain sign, everybody's favorite sign. For some reason, everybody loves the curtain sign when we were doing thoracic ultrasound in the sim lab. People just jumping when we talk about the curtain sign. But basically you have chest wall, you have the diaphragm, which is right here, liver or spleen, depending on the side that you're on, and good aerated lung coming in with A lines you saw right there, obliterating our view because we know that air is the enemy of ultrasound, right? So we see it coming in. So this tells us we have good aerated lungs bilaterally. Good. So now let's take a look at the cardiac views and see why this guy is not feeling well. So what view do we have?
With peristernal lung axis on the left and then apical flow on the right.
Good. And so what do we think?
Oh, this
peristernal long turns into a peristernal valve. Good.
The mitral valve leaflets are thickened.
Mm-hmm.
I'm not sure if it's a vegetation or.
Are these like vegetation?
Good. So we're starting to think now. And Nero, I like the way you said, hey, I see an echo density, something hyperchoic on the valves, because you don't know what this is. You have a differential again, right? Yes, I would be thinking in a patient like this, I would be concerned about a vegetation. And you can see it here on the mitral valve. You can see it here in the peristernal short axis as well. And then you see it here on the apical forechamber. So LA, LV, mitral valve, anterior and posterior leaflets, right atrium, right ventricle, and definitely we see some hyperchoic structures on the valve, which look to be right, like moving as the valve's moving. So in this young patient who's coming in with general fatigue, not feeling well, and fever, what would be your primary diagnosis? Oops, sorry. What would you think is going on?
So as we saw, like mitral valve vegetation, probably like infective endocarditis as an underlying cause.
Yeah,
for his symptoms.
that'd be something that you'd want to look at. And of course, the TTE is good, but what do you need as the next step here?
You need a TEE for better evaluation.
Absolutely.
You
need a TEE. You want to look closely at these valves, not only to confirm what you saw on your TTE, but also then to delineate the size, to delineate if there's any sort of perforation, to talk about if there's any sort of regurgitation jet that is occurring from this potential vegetation. So all of these factors are important, and they're important for the cardiac surgeons to know as well if they're going to proceed with surgery, how they're going to handle this. So all of this information you need to get, and the TE is the next best step for this patient, in addition to antibiotics. Okay. 74-year-old female, history of coronary artery disease, CHF, AFib, coming in with worsening shortness of breath. Blood pressure, she's 117/64. Pulse rate 88, tachypneic at 32, and hypoxemic to 93% on BiPAP, temperature of 99.8. So again, we get our probe out, and again, not that hard, right? You get your ultrasound, you get your phaser ready, you throw it on the chest, and we see this. So what do we see?
B profile.
Good. So this is B profile in the anterior lungs. Excellent. Remember, you can have a few B lines in your view. Up to 3 is normal. When you have more than 3, that's when we consider it abnormal. So now we look in the right mid-axillary region, and what do we have here?
Pleural effusion.
Yeah.
Good. How do you know we're not in the abdomen?
There is some lungs.
Okay, good. So, you think it's obvious, right? But you'd be surprised when you have large effusions and distorted anatomy, you might not know what you're looking at. I never look at a view without identifying key landmarks. So chest wall, diaphragm, lung. I know this is thoracic cavity. I know down here is abdominal cavity. This seems straightforward, but you don't want to bypass these small steps, because I'm telling you that we have had M&Ms on the pulmonary critical care side where chest tubes were put into the abdomen or put in inappropriate places because what they thought they were looking at was a pleural effusion, and it was just massive ascites, and the diaphragm was way up in the axilla. So these things happen, and it's not, it happens more frequently than it should, because people bypass the simple things of just finding the anatomy, understanding what you look at. Never do an intervention, never stick a needle in something until you, as the proceduralist, are convinced you know what you're looking at. So I clearly see chest wall, I clearly see diaphragm, I clearly see lung. I completely agree with you, Fatma. This looks like a pleural effusion, this anechoic fluid around the lung. What else do we see?
We can see also consolidation of the lung with diastatic bronchogram as well, and hepatization, we can say.
Yeah, I definitely see some consolidated lung. I also see some more static, I agree with you, air bronchograms, these white dots in here, relatively fixed, not moving that much. That's fluid and air trapped in the bronchi. Good. What about this fluid? Are you able to get that fluid if you need to? With a thora? What do you guys think?
If you're very, if you have a lot of experience, yes, because you have maybe 2 centimeters where it's safe, but you have a piece of lung too close to the chest wall, so maybe not.
No, that's the perfect answer. So really, a lot of procedures depend on, contextual, needs, like how good are you at the procedure itself? If this is your first thora, probably not the one you want to do it on. Very, very small window. So less than 2 centimeters, you're really pushing yourself because you don't have a lot of room to maneuver before you could hit the lung and cause a pneumothorax, or hit the diaphragm even worse and cause even more problems, right? So it really depends on how important this test is as well. So you can do it if you needed to, but I would be very, very hesitant unless I absolutely had to. And exactly how Yaz was saying, you want to look at the depth and the size. So not just the size of the effusion, but what's my safe distance? How much distance do I need to go before I get to the effusion? So I want to look at 1, 2, about 2.5 centimeters before I know I'm in there. And then maybe 3, 4 to 5 centimeters before I hit something dangerous. So I have a very, very small window. So you want to go in at least 2.5 centimeters, but you certainly don't want to go up to 5 centimeters because then you know you're going to hit something problematic. So a very narrow window. And if you were doing something like a Thor on the patient like this, you'd want to pay particular attention to how deep you're in and how many centimeters you're going in. Otherwise, you're going to cause a lot more problems than good. So let's take it to the lungs. What do we have here? I'm sorry, take it to the heart. My bad. What do we have here?
Lung axis. It's there. Actually.
It's what?
It's there. The name is there. Parasternal lung axis.
Good. And what do we have for the heart function?
So here, it looks depressed actually, based on the approximation of the anterior leaflet of the mitral valve to the septum. The septum also looks a little bit thick, and the RV looks big. Yeah,
definitely. I agree with all of your assessments. So looks like there's some LV hypertrophy. You can definitely see this on the septal wall, but also on the lateral wall. So anything more than 1 centimeter is hypertrophy. We definitely see some lack of E-point septal separation, not coming next to the septum, again, pointing us to maybe there's some depressed EF. The LA is dilated. And then we look at the RVOT. The RVOT should be less than 3 centimeters. If it's more than 3 centimeters, that's a dilated RVOT. So we have another problem here. What view?
Short axis, parasternal short axis, and we can still see that the left ventricle motility is depressed. All over I can see, and we can see also the D sign where the septal wall is like more straight.
Yeah, flattened, right? So we see some flattening. So this tells you that maybe there's some what?
Increased RV pressure, which might be secondary to like PE, pulmonary stenosis.
Just, you want to leave it at that, right? So increased pressure on the right side. There's so many things it could be due to, but definitely I agree with you. There's some septal flattening here. And then if you look at the LV, this is where, putting your finger in there, looking at the endomyocardial excursion, it looks like there's less contractility here than there is over here, right? So it looks like there's more contractility here compared to there. This is would be the anterior portion, anterolateral, ferolateral, inferior wall, feroseptal, anteroseptal, right? So looks like there's, less movement on the septum compared to the anterior and ferolateral walls. What do we got next? Who's up?
Apical 4-chamber.
Excellent. So the 4-chamber. So LA, LV, RA, RV, and what can we, what can we say about the view here or the function? So Brat, you're going to bring it home for us.
The LV function, it looks like it's depressed. And also even the RV, it's hard to comment because I'm unable to see at the lateral side of it, but looks like the RV function might also be a bit depressed. Though I see that the apical part of the RV is contracting a bit as compared to the LV.
Good. So if you can't see it, you can't fully comment on it, which is important with any image you have. But I agree with you. It looks like here we don't have good myocardial thickness or endomyocardial excursion. Another thing, I know you guys are all waiting for it, TAPSI, right, on the right side, but we also have its cousin MAPSI on the left side. So the mitral annulus plane systolic excursion. There is some longitudinal movement to the LV. You can put M mode over this annulus right here, the lateral annulus, and you can actually assess it. Anything less than 1.1 centimeters is abnormal. So we're having a few views here. E-point septal separation, bad. Myocardial excursion, endomyocardial excursion, bad. MAPSI, depressed. So we're looking at depressed left ventricular ejection fraction here.
I think we can like add that the apex of the RV is hyperdynamic in comparison with the whole function of the RV, which is indicated for McConley sign.
So, you know, McConnell.
When we see it from here, from this view, I see that the apexes of the RV looks like hyperdynamic, unlike when we saw.
So what does it tell you then? What does McConnell sign tell you?
Increased RV pressure.
Yeah, and that's exactly what you had saw before too, with some decep flattening, right? Usually, and you know, we'll have some, I don't want to give it away, but maybe we'll have some better images of McConnell sign in the future. But really, you got to get a better assessment of that lateral wall. You know, you can also look here at the tricuspid annulus, TAPSE, right? So tricuspid annulus plane systolic excursion. The right heart tends to have a more longitudinal movement compared to the left heart, which is more circumferential, right? So this is just how the fibers are aligned. So I put M mode on this side, and if it's depressed, meaning less than 1.8 centimeters, that's indicative of depressed RV function. Other things I want to look at is if I see the lateral wall out here, it looks like there's some dilation of the RV too, right? So 2 to 4.5 centimeters right here at the base. Anything more than 4 centimeters is abnormal. In the mid-ventricular part of the RV, anything more than 3 centimeters is abnormal. So definitely a dilated RV here. And the LA and the RA are also dilated. What do we have here?
Dilated IVC and non-compressible.
Good. And so this is just for anatomy, perfect view of the IVC, hepatic vein. This is what you want to see it entering into the RA. You don't want to make the common and fatal mistake of finding the aorta, like many people do, and say, hey, look how big that is, right? Everyone's hypervolemic, everyone's volume overloaded, everyone's CVP is through the roof. These are right next to each other, these structures, and they're you're easily able to misidentify them. So you want to see those typical features. So what can we say about this IVC? Yasmin was starting on it. What do we think?
We can say it's dilated with no respiratory variation.
So what does that mean to you?
It's an indication for also increased right side of pressures.
I love it. So increased CVP is what you would say, right? This is important because when you're actually doing echo, you want to look at this IVC because you need to know what the CVP is in order to calculate right ventricular systolic pressures and pulmonary pressures, right? So if you're, and that's important too, because if you're going to calculate, you know, mitral regurgitant jets and everything and the different pressures between the RA and the RV, you need to have a good view of things like the IVC. The IVC does not tell you volume status. It tells you CVP. CVP may be a marker or, you know, an indicator for volume status, but it does not directly correlate. And in fact, there's a lot of data out there saying that, you know, even when people are volume responsive, sometimes they have dilated and IVCs with no variation. So this by itself shouldn't dictate if you give fluids or if you don't give fluids. It's just one piece of the puzzle. In spontaneously breathing patients, and that's how we always want to remember that. And for the vast majority of the time, we are looking at spontaneously breathing patients who aren't on ventilators. Now, the one exception in a spontaneously breathing patient is something we call a virtual IVC. So if you have a very slit-like IVC, if your IVC looks like this up here, right, and there's collapsibility with respiration, that's what we call a virtual IVC. In those cases, the vast majority of the time, they will need fluids, and you would want to give those patients fluids. But other than that, unless you have somebody intubated, paralyzed, in normal sinus rhythm with no underlying cardiac dysfunction, no increased pulmonary pressures, you really can't use the IVC as a marker of volume status. But very important when you're doing echocardiography and you're trying to look at RV systolic and diastolic pressures and pulmonary pressures. So we talked about a lot. So cardiac, what did we say? And I keep hitting it and I gave it away. Nero's smiling like she knows. So what did we see in the cardiac and the thoracic views? Somebody. We got 2 more cases. I want to get through them.
Okay, so I don't remember the thoracic view, but I think this is the guy that had the pleural effusion and also had biventricular dysfunction and the dilated IVC. So we can say that this is all like fluid overload.
So biventricular heart failure with severely depressed left ventricular ejection fraction, B-line profile, pleural effusions, consolidated lung with static air bronchograms, IVC, more than 2 centimeters with no respiratory variation. This is how we break it up. The CVP is anywhere between 10 to 20, on average about 15. There's spectrums here. So if the CVP, the IVC was less than 2 centimeters with respiratory variation, more than 50%, we'd say it's between 0 to 5 or average about 3. And then anywhere in between. So dilated with variation or smaller with no variation, those are in between, right? So this is how we want to get our assessment of CVP. Again, very, very important for advanced echocardiography. So acute on chronic systolic heart failure with pulmonary edema and pleural effusions, just like you said, Yasmin. So we talked about this. She's raising the roof in the background. We talked about this. How do we evaluate left ventricular function with POCUS? You know, with point of care ultrasound, a lot of this is eyeballing, E-point septal separation, myocardial thickness, and a myocardial excursion, longitudinal shortening or MAPC. Other ways you can look at fractional shortening in LV and RV. You can look at fractional area change. You can use the Sampson method, which is obviously the best mode beyond the scope of this. But when you're looking at POCUS, use these 4 things. And if you use these 4 things, you will be able to determine if somebody is hyperdynamic, normal, or depressed or severely depressed. How do we evaluate right ventricular function? Everyone's favorite, TAPC. But now maybe you'll start using the term MAPC. For those of you, I know that a lot of you going into cardiology, this is one of the reasons why you want to get different views. Different views correlate with different areas of the heart. Different areas of the heart correlate with different areas of coronary perfusion. So if I have my apical forechamber, this is my anterolateral wall, apical cap, inferoseptal wall, obviously different coronary perfusion. If I then rotate counterclockwise 60 degrees from this apical 4, I get an apical 2, also known as an apical long axis, and I get my anterior and my inferior views of the heart, different coronary perfusion. And then if I rotate another 45 degrees, I'll get an apical 3 chamber. And this is my anteroseptal wall, and this is my inferolateral wall. So different coronary perfusion, you can look for these wall motion abnormalities. Just as important as then taking it towards a short axis and then looking at the different areas of the wall. We did that with the previous echo. And then you'll be able to isolate to some extent where you think there might be deficits in coronary perfusion. And this is how you want to do it. Simple, can be done at bedside echo. Not that complicated, as long as you're able to get the views that you want to get and the views that you need to get to be able to make a diagnosis. As Subrat was pointing out when he was reading the echo, if you can't see the RV-free wall, then you really can't comment on the RV-free wall. So always take that into consideration. If there's limitations, acknowledge them, do what you can and move on. But don't jump to diagnosis if you can't fully see something. So that was just for those of you who are interested in a little more complicated stuff. So we have 2 more cases, and these are 2 good ones. So you got a 28-year-old female, 29 weeks pregnant, shortness of breath, lower extremity swelling, AC's worst nightmare when it comes to a call, right? Especially at 3:30 in the morning. Patient's hypotensive, tachycardic, tachypnic, hypoxemic, they're febrile. The OB residents, besides freaking out, they decide to get a chest x-ray. And it's read as normal. So they start heparin, they call you, they say PERT, let's get it going. I got the TPA ready, let's start pushing it. You say, let me see what's going on. Let me evaluate the patient. And you decide to bring the ultrasound with you. So what do we have here?
So Brad, do you want to say something?
No, just like looking at the long axis. No, I was not saying anything. Yeah, it's a pasternal long axis. I think from looks like the ventricles are contracting okay-ish, I guess, and RV looks okay. Yeah.
What do we have here?
there's a short access at the papillary muscles, I would say. Good contractions of the LV.
Excellent.
Yeah, RV looks okayish as far as I can see. Yeah. Again, the apical four-chamber, like without quantifying numbers, looks like decent contractions of the ventricles bilaterally.
Let's take a look at the lungs.
We can see A lines on the right one. I'm not really sure what I see on the left one. I'm not really sure.
So
as in the right anterior, I'm not sure what we're looking. The left anterior looks like we have A lines. Yeah.
Good. And so on the right anterior, what do we have here? So what do we say?
Confluent B lines.
Okay, so you see some B lines down here, right?
Yeah.
So what's all this?
Yeah, this is like thickening of the pleura or this bumpy sign.
It's the bumpy sign. I like it. Maybe they're using that, the bumpy sign. But you're getting there. You're getting there. Just describing it, you're starting to see some abnormality, right? So definitely there's some B lines here. Oh, sorry. You see some B lines here, here, over there. So what's going on up here, though?
It's very irregular looking. It's actually kind of hard to see if where the pleura is or if it's like below or above, I mean, anterior or posterior to that irregularity. And it's also immobile looking. So I don't know, maybe you could consider more like a mass or something that's fixed to the chest wall.
Good. So it looks like a consolidated pattern, right? There's some sort of consolidation here. Whether or not that's mass, pneumonia, it's tough to say. We actually call this, there's two things that we say here. This is what we call a shred sign. Have you ever heard that before? So irregularity in the pleura and subpleural, the pleura would be up here, but you don't really see it that well because there's so much inflammation. These subpleural echoes and irregularity in the lung is what we call a shred sign. So you can actually see some aerated lung, and then around here you see these irregularities right next to it. So it's like a shred. And then this consolidated pattern anteriorly is known as a C profile, so consolidation. And by far the most common cause of consolidation in the lung is what? You know, just
pneumonia.
Pneumonia, right? So usually that's associated with pneumonia. But C profile, when you see that consolidation anteriorly, and then the shred sign, that irregularity in subpleural echoes. So now you look in that right axillary region, and what do we have here?
We can see the dynamic bronchogram and consolidation of the lung.
Yeah, definitely.
It looks like hepatization of the lung, doesn't it?
Yeah, consolidated, hepatization, dynamic air bronchograms. So what are we thinking?
Pneumonia.
Good. So normal left ventricular ejection fraction, normal right ventricular size and function, right C profile with the shred side and consolidation with dynamic air bronchograms, A profile on the left. So acute hypoxemic respiratory failure due to pneumonia. So what's your treatment recommendation to the OB team?
Antibiotics, fluids.
Yeah, and maybe stop the heparin, right? So you'd be surprised, but when you use ultrasound, you'll be able to find a lot of these details, which can really change the clinical picture. So these are real cases. Some of these are real cases, and we've had this before where people think it's a PE, and there's other things going on because everyone just remembers some of those incidences where obviously we've had some young patients with PE, sticks in your head. But definitely the ultrasound proved that wrong. You didn't see any RVOT dilation. You didn't see any sort of septal paradoxical septal wall motion. So certainly the shock or the hypotension, everything was due to something else.
Dr. Salonia, just a small question regarding the last case. You mentioned that the chest X-ray was read as normal. Do you expect it to be absolutely normal with such kind of hepatization? Like,
so all you have to do is Elizabeth on the call right now? She's my AC. People read things differently. There has been many times where the chest X-ray is read as normal, and there's a and you've probably seen it too, there's an apparent pneumonia. When I was in the ICU 3 weeks ago, they had a CT because we thought there was a PE. It was read as no PE. We reviewed it with the team. I don't know if you were on, Sabra. I thought maybe you were on. We read it. There was clearly a PE. We called the radiology. The attending radi goes, yes, there's a PE. We missed it. So things get missed. Overnight, a lot of the time, you will be having a resident read the chest x-rays, right? So I said overnight resident read the chest x-ray, read as normal prelim. And also, you'd be surprised how chest x-rays will be very unimpressive. And then you throw an ultrasound there and you see some dense consolidation. Those of you who are using ultrasound more and more in your clinical practice, you'll start to appreciate that, as I have. So chest x-ray is okay. Ultrasound is much better at looking at the lungs and looking for those dense consolidations. So something like this obviously can happen on many, many occasions. So ultrasound is very important to incorporate. So last case that we have here, it's a good case. So 71-year-old female, hypertension, CAD, COPD, chronic steroids, presenting with chest pain and shortness of breath. This was actually a patient of mine that I got called at 2 o'clock in the morning to see. Hypotensive, tachycardic, tachypnic, hypoxemic, 91% on 6 liters, febrile, slightly to 100.9. Cultures were collected. She was started on vancomycin and cefepime. She was admitted to the general medical floor, and thankfully the resident on said, hey, patient's a little borderline in terms of blood pressure, tachycardia, a little hypoxemic. Let's call a critical care consult and see this patient. So we go down, we see the patient. We take a look here, and what do we see?
A profile.
Excellent. A profile bilaterally. Let's look at the axillary regions. What do we see?
The curtain sign.
Your favorite, the curtain sign. You guys have now seen it twice, so everybody should be going crazy. What's this view?
External long axis.
Good, and what do we think?
Oh, the RV is very impressively enlarged, and the septum is basically deviating in two, or it's flattened, I'm not sure. It's just the LV cavity looks really tiny, and it's hyperdynamic.
Excellent. So LA, LV, RVOT up here, definitely bigger than 3 centimeters. There's, displacement of the septum towards the left ventricle, which is abnormal because the left side is a higher pressure system than the right side, correct? What do we have here? Nero, is this going to be your case? Are you taking it home, or is Matt going to come in here? I see he just...
Seems like there's bowing of the LV of the LV wall, septal wall.
I gave you a perfect view right here. So if anyone wants to trace that out, that's a D.
Yeah.
Right. So LV, RV, we definitely see that paradoxical septal wall motion. It's important when you're looking at the septum, is it going into the LV during systole or diastole or both? If it's occurring during systole, that's a sign of RV pressure overload. If it's occurring in diastole, it's a sign of RV volume overload. Very difficult to just eyeball it. With ultrasound, you really have to have EKG leads so you can see the QRS complex, know when you are going into systole, know when you are going into diastole. But definitely we see that paradoxical septal wall motion, right? All right. As I promised, because I always deliver on my promises, this is for you guys. You were saying it earlier. What sign do you see here? McConnell sign, right? So McConnell sign, you have this dilated and hypokinetic free wall of the RV with hyperkinesis of the RV apex. If we were to just eyeball this, definitely the RV is equal size or even larger than the LV, which is abnormal. It should be less than 2/3 the size of the LV. So just eyeballing it, we know it's abnormal. But why does McConnell sign occur?
Because of increased RV pressures and decreased LV filling, the LV is hyperdynamic. So really the LV apex pulls the RV apex down towards itself. And then the rest of the RV free wall is hypokinetic. So you just tend to see like the thumbprint sign.
Spoken like a brilliant cardiologist. Perfect, Neero. So definitely increase RV pressure overload acutely. The RV is a thin-walled ventricular structure. It hates afterload. It cannot handle afterload. The LV can handle tons of afterload. The RV can't handle any afterload. All of a sudden, you increase the pressure from anything, but usually with acute change, it's a PE until proven otherwise, but not always. It's a sign of pressure overload. That pressure overload dilates the RV. You then have hypokinesis of the free wall to compensate, because now you have decreased cardiac output from the right side to the left side. The LV starts to increase its contractility. You become tachycardic, right? And so the muscular wall of the LV is pulling the thin apex of the RV. And so you get this pinching down. It's almost like putting your index finger on top of it, pushing it down. That's known as McConnell sign, right? Very clear, it makes sense. If we were to do TAPSE on this patient, putting M mode over the lateral annulus, you want to measure from peak to valley, right? So this is the valley, up here is the peak. You want to look at the distance because this moves more in a longitudinal direction. And this one is actually 1.1 centimeters. So we said less than 1.8 is suggestive of right ventricular dysfunction. So certainly abnormal. Those of you who are also interested in more advanced stuff, you can also use tissue Doppler if you're familiar with that. And I can look at how tissue moves. And I can look at the S prime tissue velocity. Anything less than 13 centimeters per second shows decreased function of the RV. That's more complicated, but easy enough to do with POCUS in the right hands. So you can look at different ways of looking at, excuse me, depressed RV function, which clearly you see here. So your next step in the workup, this was supposed to be animated. I don't know why it came up. I was supposed to have you guys say CT chest, but somebody said CT chest, so here it is. And there you see, obviously, a saddle embolus, right, sitting on the main pulmonary artery. Hold on, now it's freezing on me. There's the main pulmonary artery, left, right. You see that saddle embolus, dilated pulmonary artery. So how do you manage this patient?
Activate PERT.
Activate PERT, yes. And this patient in 2:30, 3 o'clock in the morning went uptown and had a surgical embolectomy. They were able to extract the clot, and she did quite well. And in a week and a half, 2 weeks, she was able to leave the hospital. Around 2 weeks, I think she left the hospital, but she did very, very well after the surgical embolectomy, was extubated within 24, 36 hours, weaned off milrinone within 36 hours, and out of bed to chair in like 3-4 days and doing great. And yeah, she did quite well. So you could see how this patient was admitted with a diagnosis of pneumonia. Definitely could have been pneumonia, but ultrasound really helped to change the course here by looking at those lungs, looking at the heart, then coming up with a differential which made more sense, getting the diagnostic test that needed to be done, and then sending the patient where they needed to go so you could have these optimal patient outcomes, which really is what we're trying to teach here, right? How you can use this tool to better manage your patient, to deliver better, high quality care. And that's what it's really all about. We're done. You guys did phenomenal. It's a very complex cases. These are not easy cases. You know, take it systematic like we were doing, and you'll never make a mistake. You'll always catch up the little things. Those of you who are interested in reading a little more about POCUS, there's a POCUS journal out there, which has some pretty good articles, some good case reports, things that you can read. Chest has an ultrasound corner. It's published monthly. The editor is Seth Koenig, great guy. I teach with him out in Chest in Chicago. He's the editor for Ultrasound Corner. He also has a lot of videos, Better with Ultrasound. He works a lot with Paul Mayo, probably the two biggest names in point of care ultrasound. The POCUS Atlas is a great platform for viewing images, both normal and abnormal. It also has cases that you can go through. So you can have, much like we did here, clinically integrated cases, so you can refine and continue to develop your ultrasound skills. And here's some great websites. So you might be familiar with this one. It's the one that Fernando Vasquez, our third-year fellow, created. It's the whole ultrasound curriculum that we still utilize today. These are resources that you should still be getting with your ultrasound elective. This is something that we developed. And when I gave these to Dr. Rothman, He incorporated these hopefully still into the email that you get. This is from the University of Toronto. They have great TTE and TEE images. For those of you who are interested in going into cardiology, you'll need to know your TEE. And then ATS has a lot of great resources for you to review. So between all of this, you have more than enough resources to keep your mind occupied. And we also have a great curriculum here. You have a lot of faculty who are dedicated in teaching you point of care ultrasound. So please reach out, feel free to utilize us. There's images you want to go over, things you want to, go over, just always set up a time, pull us aside. We're more than happy to help out. With that, I will dismiss you for 5 minutes for a bathroom break. And don't worry, our hypoxemic respiratory failure will be quicker. It's not going to be as long. I really wanted to hammer home a lot of these key POCUS concepts because I know this is an important thing for you guys. And many of you are really showing a lot of initiative in POCUS, and some of you are going into cardiology and critical care. You'll need these skills. All right, so